All right, well, let's go ahead and get started. For those of you who are just joining us, welcome. My name is Matthew Menendez with White Plume, and I appreciate your time this afternoon. I hope that this will be helpful for you. Let me start by going through what I hope to accomplish with you over the next 45 to 50 minutes. We'll start with just a bit of review, talking about risk-adjusted coding, what we looked at last week, the two big changes that we have to diagnosis coding that's coming up. Number one, when the payers begin to crack down on unspecified codes, right? That is going to significantly impact our denial rates in our practices. But the longer term change that has a bigger impact is our payers are going to start using our diagnosis codes for risk adjustment. They're looking at the severity, complexity, acuity of your patients and your patient populations, and that's going to be used to measure your quality scores and your cost scores under MIPS. So we're doing just a little bit of review to get everybody's brain back in the right spot. And then what I really want to spend the majority of our time on today is looking at how do we put this into practice? How do you operationalize this in your organization? One of the questions that I frequently get is, well, what should my target be? What's the benchmark? What am I aiming for? What is my goal when we really start to talk about HCC coding? So we're going to go through that. I'm going to share some data with you so you can look at how your practice may be doing today, what tools are available out there to take a look at how your practice is doing today. Some of you are probably already deep into this. For others of you, you may be just starting or just starting the thought process on this. That's okay. We're going to try to give you some tools so that you can understand what the goal is, where you are today, and then how do you think about putting a plan together to make sure that your practice is accurately representing your patient population acuity. All right, so we're going to go through, we're going to talk about that, and I'm going to try to give you some good, practical, specific examples of what other practices are doing. How have we seen our clients who already have risk-adjusted contracts, how do they handle this? Our clients that are part of ACOs that have to understand what that risk-based portion of their population looks like. How do they handle that? I'm going to try to share some of that with you today so that maybe you can take some of those ideas and put them into practice in your own group. All right. I'll make sure that we leave time for questions and answers at the end. So if you have questions as we go, feel free to put those in the questions section, and I'll make sure that we handle as many of those as time permits. So if you're just joining us, welcome. We are glad you are here this afternoon. So quick review. From a very high level perspective, you remember the government and the commercial payers are trying to move towards the triple aim of healthcare, right? Better healthcare at lower costs and improved patient experiences. And in order to do that, the government cannot do this alone. They have to involve physicians. They have to involve patients. And we are seeing that through the risk transfer off of the payers onto those two categories of people, onto patients and onto doctors. You've seen this in your own experiences with higher premiums, higher deductibles. That puts more of that risk onto patients, right, in an effort to try to better engage them in this process. But we also see that risk being transferred to physicians. We're trying to move away from the fee-for-service model towards an outcomes-based reimbursement world, a quality-based, value-based reimbursement world. And that involves quality measures and resource use. That's what we see as the two big components of MIPS that the government's going to use to reallocate some of those dollars. And in order to accurately measure quality, in order to accurately measure cost, right, you have to talk about risk adjustment because there are many factors that are outside of physicians' control. And what that means is our diagnosis coding is how we communicate how sick our patient population is. Our diagnosis coding is how risk adjustment is handled. The government's preferred methodology for risk adjustment is HCC coding, and what that means is our diagnosis coding becomes much more important than it ever has been before, right? We talked about this last week. For a long time, physicians have been paid for CPT codes, and they needed a diagnosis code that made it medically necessary. Last year, 10 months ago, we made the switch to ICD-10. A lot of people were concerned about increasing denial rates. It really hasn't happened yet. We believe most of that is still ahead of us, as the payers have had this grace period under ICD-10 where you were not penalized either by denials or under the PQRS or value-based modifier program for lack of specificity. But that grace period expires in just over 60 days. On October 1st, 2016, the payers are expected to begin to start to crack down on your diagnosis coding. But still, even if your claim gets denied, the life cycle of that diagnosis is really over and done within 30 days. You can resubmit the claim, make sure that it gets paid, but the second change that's coming adds a much longer tail to how you do your diagnosis coding, because it will impact next year's risk adjustment scores. It will impact your MIPS, either penalty or bonus, 2 years into the future. So what you do in 2017 from a diagnosis coding perspective has a much longer tail, and that's what we want to make sure that we get out ahead of. You remember the example that we looked at was 3 identical patients who needed total knee replacement surgeries done. And what you code tells your payers how sick your patients are. Most people are not doing this today. And the reason why is under fee-for-service, each of those 3 patients, the reimbursement is going to work exactly the same way. You have a diagnosis code that makes that procedure medically necessary. In the 4th quarter of this year, we expect that patient number 1, that claim is probably going to get denied. You're not specific enough. You need to replace that at least with the type of osteoarthritis and the laterality, right? But the bigger impact is actually in the risk adjustment. When you look at the HCC score for each of these 3 encounters, you can see that the HCC score is vastly different for patient number 3 than it is for patient number 1. And that's because we've included these comorbidities of morbid obesity and type 2 diabetes with polyneuropathy, right? And remember, the HCC score is what the government uses to set the targets for how much they expect to spend on that particular patient, right? So if those are the only 3 diagnosis codes that particular patient had, patient number 3 compared to patient number 1, Medicare expects to spend over $6,600 more on patient number 3 over the next 12 months than patient number 1. Right now, you're always going to have some pushback on this. You've got doctors who don't want to do this. That's not what they got into medicine for. I only code the primary diagnosis. That's all we need to get the claim paid, right? And so when we think about this, I get a lot of questions about, well, what's my target? What's my goal? Is there a certain number that we should be shooting for? I wish the answer was yes. That'd be a lot easier if you could just quantify that. But the goal is really to make sure that you are accurately showing how sick your patients are, right? That you're accurately depicting patient acuity in your patient population. That's important to make sure that we get the right targets set as we transition from fee-for-service to a value-based reimbursement rule, number 1. Number 2, we know that the government wants to publish cost data, to publish quality data on the Physicians Compare website, right? Any patient has access to that if they're looking for a cardiologist in your particular town. Nobody wants to come up as high cost and low quality, right? It's important to make sure that you get credit for the excellent patient care your doctors deliver. And it's very, very hard to do that if you're not accurately reflecting patient acuity. Number 3, we talked about this a lot last week. 60% of your MIPS score is tied to quality and resource use, quality and cost. And those scores are going to be risk adjusted. So we want to make sure that you're not setting an artificially high target just because you haven't shown how sick your patients are. We need to make sure that we get that right. Okay. Number 4, We know that it's not just Medicare that is trying to go to risk-adjusted contracts. The commercial payers are following suit. So Blue Cross and Aetna and United are moving in this direction as well. And we want to make sure that that is done correctly. Because the payers, they are already using this data today. They're already taking your diagnosis codes that you submit on claims every single day and using that to translate those to the HCC codes so that they can get a patient acuity score for your patient population as well. And if your payers are using this against you in contract negotiations, it's very important for you to understand this as well, for you to be equipped with this data also to level the playing field, to make that more of a fair fight when you have contract renewals with your insurance carriers. Because if you haven't seen this happen yet, if you don't have risk-adjusted contracts yet, that's probably coming in the near future, okay? So the target is not a specific number. The target is to make sure we're accurately reflecting patient acuity in your patient population. Now, let me share some results with you of kind of where people are today. We did the poll in the webinar last week. I'll share some of those results with you as well. We found that about 20% of practices are either currently monitoring HCC codes and or they already have risk-adjusted contracts with commercial payers, right? So the majority of you have not done that yet. About 1 in 5 have experience with that. The majority of practices do not have that experience yet. Now, that being said, nearly 60% of you said that your doctors do a good job of usually documenting the comorbidities, right? So in the prior example, the morbid obesity, the diabetes with polyneuropathy, that's in your note. That is in your note, but only 19% think that their physicians are doing a good job of coding those comorbidities. So number 1 and number 3 typically go hand in hand. The groups that are paying attention to this have usually done a better job of getting their doctors or coders to actually code those comorbidities, right? So for most of you, I want you to see that the majority of people are not doing this yet, right? We've got work to do, but you're not alone. You're not alone. The majority of people have not done this yet. So how do we get better at this? How do you put this into practice in your organization to make sure that you accurately reflect patient acuity? Well, what I'm going to recommend is really a 4-step process. And it's a 4-step process that repeats. It's probably not a one and done for most of you because the work is never over. We're constantly wanting to make sure that we're accurately reflecting patient acuity. So the first step is education. Hopefully that's what we're doing today, giving you a bit of information to get your mind in the right place, to equip you with some tools and some resources to be able to put this into place for your practice. Now, once you've gotten some awareness up, not just for you, but for your revenue cycle team, for your clinical teams as well, then we need to do a little bit of analysis to say, where are we today? Do I have any doctors who are doing a good job at this? You know, what are our most commonly used HCC codes? How do I use that information to actually operationalize that and put that into practice in my organization, right? And that's where we're going to spend the majority of our time. Because after I've done my education, after I've spread some of that knowledge around and done our analysis, how do we put that into practice? What are the nuts and bolts of how some groups are already doing that today? That's where we're going to spend the majority of our time in that third step. And then after we do that, we want to go back and review our progress. Where have I been successful? Where do I still have additional work that needs to be done? You know, go back, review that progress, and then I'm right back into education so I can show my doctors, I can show my nurses, I can show my coders where we still have some work to do so that we can get busy getting better. Okay, so I would submit to you that 4-step process is really what we're looking for. It's a good framework as far as how to think about getting better at accurately reflecting patient acuity. So let me talk about each of those briefly. From an education perspective, like I mentioned before, we're hopefully doing that for you today. I hope that this has been helpful for you to open your eyes to where risk-adjusted coding is going to be important, why HCC coding is going to be very important going forward. We do have the recorded versions online for both Part 1 and Part 2. So if you would like links to either of those or both, let us know. You can use the question section for that. I'll make sure that we get you those links. We can get you the slides that are available. This may be helpful for you in conversations with your revenue cycle team. Talked to a client earlier this week who had one of their certified coders who was pretty familiar with HCC coding, but for everybody else this was brand new. So they used some of this material as internal training to help get their revenue cycle team on board. I would also recommend sharing this with your clinical staff and with your physicians. They don't have to be experts, but they need to understand what's important. They need to understand why we're doing this. And so the two things that I would want to make sure that I communicate if I were talking to them is, number one, what is risk-adjusted coding? Because it is a little bit different than what we've done under fee-for-service for the past 35 years. That is a change, right? For people that are familiar with DRGs in the inpatient world, this is not as big of a change. It very closely mirrors what's been happening on the inpatient side. And then the second thing that I want to make sure that I communicate from an education perspective is, why is this risk-adjusted coding so important, right? If you don't understand why it's important, how it's going to impact you, your practice, your daily life, it's going to be very difficult to go through the rest of the process. It's going to be very difficult to make any measurable change, and it's going to be very difficult to get any better at accurately reflecting patient acuity. That's why I think education is so important, and that's why that's the first step in this process. All right, step two is the analysis portion, right? And I think this is a critical step. Don't skip it. You need to understand, once you start to look at the data, it becomes very, very helpful to have more meaningful conversations with your coding teams, with your clinical teams, with your physicians. And I'm going to show you how we tie that analysis to the process improvement. One of the things that I shared last week, just to give you a bit of a frame of reference, was some average HCC coding, right? You remember probably that HCC coding has two components. It's demographics plus diagnosis equals your HCC score. There's not much that you can do to change your patient demographics, right? The things that impact patient demographic HCC components are age, sex, Medicare eligibility status, so you can't do much to change that. So what we see, the difference where you actually can control it, is in your diagnosis coding. So what we're doing here is looking at the average HCC per diagnosis. Now you can see some specialties are obviously going to be much higher than others. Oncology, nephrology, endocrinology, cardiology, those are going to be towards the top. And the reason why is that the patients that they treat, the primary conditions that they treat, typically have higher HCC weight than what you see in primary care or some of the other specialties. But remember, the pediatrician is not being compared to the oncologist, right? They do very, very different things. They're being compared to other people within their specialty. And so when you look at this and get a bit more granular, and you look across practices within the same specialty, right? The average HCC per diagnosis within orthopedics is closer to 0.016. But again, we see that some of the practices at the top of this list are doing twice the average. And some of the practices at the bottom are half the average. That means there's a 400% difference between some of the best performers and some of the worst performers. So we have to ask ourselves, does that mean that the best performers, their patients are 4 times sicker than the worst performers? Probably not. Probably not. What the difference is how they do their diagnosis coding. Are they capturing some of those other comorbidities, right? Or are they only coding the primary diagnosis? And if we drill down even further and look within a practice, now we're within the same specialty, we're in the same city, we're within the same four walls, and you've got 30 doctors in the same practice, and the top 10% are doing over 10 times better than the bottom 10%, right? The difference is not in patient acuity. The difference is in how they code. But remember, the payers only have the data that you submit to them. We are giving them the data that they are turning around and using against us. So you've got to be very, very careful in how you do your coding. That's why diagnosis coding is going to be much, much more important in the future than it ever has been in the past. And that's why we want to get out ahead of this, so that you're accurately reflecting what your patient population looks like, so that you're accurately reflecting how excellent clinical care is delivered in your practice and how well you do for the dollars that Medicare spends on your practice, so that that's accurately reflected when they go to do the Physicians Compare website as well. So I think it's helpful to look at how your doctors are doing today. I think it's also helpful to look at what the most frequently used HCC codes are across the country. These are the top 10 ICD-10 codes and their HCC values that are used across the country. So part of the question is, are your patients look like this also? Do they have these sorts of problems? If so, are they documented? If they're documented, are we capturing that from a coding perspective or not? And is there a difference in some of our providers are doing better than others? How do we improve everybody's performance with this? It's helpful to do some analysis. There's some deeper analysis that can be done that I'll show you a few examples of later. But doing this type of analysis helps you give relevant examples that's supported by data to your physicians that helps explain to them what risk-adjusted coding is and why it's important to them. Education first, data analysis can be used to help make that education better, and we can use those two items to make sure that we're successful when we try to operationalize this in our practice. Now, I think it might be helpful to show you a couple of things that we've seen people make mistakes on when they've tried to put this into practice before, so that you won't make the same mistake, right? Mistake number one that we've seen is people try to put all of this work on their physicians. They try to put all of this work on their clinical staff. And the justification usually goes something like this. Well, they're the only ones that are in the exam room. They're the one that's ultimately responsible. You know, they're the ones that had the patient visit, right? We have to make sure that our physicians are doing that work, right? And the challenges with that is that our doctors need to be focused on taking care of patients. That's why they went to medical school. That's why they wanted to be doctors in the first place, was to take care of patients and to help their community, right? And there's been a lot of change over the last 5-6 years in our industry, and the physician burnout rate is much higher than it ever has been before, right? Meaningful use was very difficult on physicians. They've had to click more and interact more with the computer than they were ever interested in doing before. We don't want this to be exacerbating that problem, right? We don't want to turn our doctors into coders. And I've seen practices make that mistake when they try to move towards this value-based world. We need to make sure that we don't do that in a way that negatively impacts patient care or negatively impacts physician productivity. Now, the other mistake that I've seen people make is on the other extreme, is that says, you know what, I'm going to put all of this work, I'm going to put all this responsibility on the revenue cycle team. My billers, My coders, they're the ones that can do this. They're the ones with the coding expertise. They're the ones with this type of knowledge, right? And we're going to put that on them. The problem there is obviously that most people are not staffed for that today, right? Most of you don't have certified coders that are going through, that are reading every single note and coding directly from that note. And now, you start to read a lot of the consultants, people that are familiar with the DRG process and inpatient coding. You know, that's what they do. They have an HIM department that is able to code from the note. As long as the physician handles the documentation, the coders handle the rest. And they go through, they look for every single diagnosis they can find to make sure that it's coded out to the highest level to maximize their DRG value and their reimbursement, right? Most physician practices are not staffed for that today. And most of the staff that they have are not trained or not certified from a coding perspective to do that, right? It's not that they are not excellent revenue cycle employees, but they may not have that level of training, right? The people that have that level of training are working for the hospital. And the third part is, and the reason why this hasn't happened, is that the return on investment doesn't really make sense for a busy, high-volume private practice. It's very difficult to staff up with the quality coding staff that you need in order to code out to the highest level. And you look at it and say, well, is there an ROI in the future, right? Maybe this is an investment opportunity for the practice. You know, looking at the way that MIPS works, it doesn't look like the incentive payments are going to be large enough to where it'll cost justify that type of expense in the future, right? So what is the example? You know, how do you blend these two? It's a balanced approach, right? It's going to take our clinical staff and our back office revenue cycle staff working together to make sure that we accurately reflect patient acuity, right? And that means we need to provide them with specific and relevant education as to why risk-adjusted coding is important, why are we doing this, and how do we operationalize this in a way that doesn't turn your clinical staff into coders, right? That makes it easy for them to understand, makes it fast for them to help with this, but then also making sure that the revenue cycle team has tools that they can use to identify when the clinical team might have missed something so that they can make those corrections, so that that doesn't fall back to the physicians, so that doesn't fall back to the nurses or the other clinical staff. So we want this balanced approach. I think I'd put that in your mind. And some of you may be further to one end of the spectrum than the other. I don't think this is a one-size-fits-all. What I'm hoping to try to give you today is a framework for how to think about this and to show you some tools as to how some of our clients have done this before. All right? So let's get down to the nitty-gritty. Let's look at some specific examples. It always helps me. Hopefully this will help you as well if you're a visual learner like me. So let's go back and look at those most frequently used HCC codes. I think you could look at this one of two ways. You could look at it, number one, what are the most frequently used HCC codes across the country, this list right here. Or if you wanted to get more specific, you could do some analysis, and I can show you how we can help you with that. If you wanted to see what are the most frequently used HCC codes in my practice, right? Either way, top 10 is a good place to start, all right? So let me show you how one of our clients integrated this into their workflow. So here's what they did. We're going to go back to that osteoarthritis of the knee example that we talked about before. They used to just code the ICD-10 code, right? Osteoarthritis of the left knee. Got it, right? We're specific enough for ICD-10. We're not going to have that claim denied, but they kind of moved on from here. They didn't stop. They didn't code the comorbidities, right? So what they did was they added a little section right here that said comorbidities, right? And what this group did was when you clicked on comorbidities, they would get a quick pop-up here that showed those top 10 most frequently used HCC comorbidities. So it would show you the description, it would show you the weight, so that you can see there's a difference between diabetes with and without complications, and it would show you the ICD-10 code as well. So it makes it easy for the clinical staff, whether that's a doctor, whether that's a PA, an MA, a nurse, a scribe, somebody on the clinical team, to quickly say these were the other comorbidities that this patient had. Not only did we document it, but we also coded it for the encounter. Okay, that's one way that a group tried to make this easy for their clinical staff. Let me show you another way, using the same example, right? This time, what's different is instead of putting that in a pop-up, in what we call a custom scenario, they list out those most frequently used HCC codes. They put them right there on the face of this form, and again, they put the weight there to remind the clinical team of how important that is, right? Because if this practice has an average HCC per diagnosis of 0.05, right? Just coding morbid obesity on the 6% of your patient population that has a BMI of greater than 40 brings up that average significantly, and make sure that you're accurately reflecting what your patient population looks like, right? Trying to make that easy for the clinical staff. Trying to make it easy for them to accurately show what your population looks like. Now, let's look at another example. And we'll go to the other end of the spectrum and talk about the back office for a second. Because not all HCC codes are created equally, right? Just taking a look at some of the ICD-10 codes that are within the same code family, E11, type 2 diabetes, you can see one of these things is not like the other, right? One of these things just doesn't belong. One of these things is not like the other. See if you can figure it out by the end of my song, right? For those of you who are Sesame Street fans, you can see the type 2 diabetes without complications, E11.9, the most frequently used HCC code, has a weight 3 times less than the other type 2 diabetes with complications. Even if you don't know what the complications are, E11.8, type 2 diabetes with unspecified complications, that has 3 times the HCC weight, 3 times the patient acuity value that type 2 diabetes without complications has. So not all HCC codes are created equally. And when we talk to coders, when we talk to revenue cycle teams who are paying attention to this, one of the things that they notice is sometimes the doctors, sometimes the clinical team would use E11.9 when they really shouldn't have. And how do they identify that? How do they do that without looking at every single encounter? And so let me show you the example of what they did. They capture all their charge data in their EHR. They use this as a back office tool to identify coding problems. So they built in a rule that says basically, I've got 2 diagnoses here. There's that E11.9 that we talked about before. And the secondary diagnosis is I12.9. So that is chronic kidney disease. So they built a rule that says when I see a diagnosis of diabetes without complications and chronic kidney disease on the same patient, I want you to stop me and have me take a look at that. Because if the chronic kidney disease is a result of the diabetes, that means that we really shouldn't be using E11.9. We should be using one of the other diabetes codes, diabetes with chronic kidney disease, diabetes with renal manifestations, right? So it's trying to catch these and provide the revenue cycle team to provide the coders with the tools that they need in order to code this correctly, right? So you can help some of that on tools for your clinical team. You can use some of that as tools for your revenue cycle team. Let me show you an example of how you can do a little bit of both. an example of how you can do a little bit of both in this third example. I think this is the most powerful example that we'll see. This is from a client of ours. It's in a cardiology practice. They have more than 2 doctors. This practice has about 60, but I try to use this to simplify a comparison of 2 doctors. Dr. 1 is not the best at this, but is in the top quartile, right? Average HCC per diagnosis of 0.07, right? Significantly higher than the practice average, 0.046. Provider 2, again, not the worst, kind of in the top of the bottom quartile, 0.039, right? So just looking at that, right, we would say Dr. 2's patients are nearly twice as healthy as Dr. 1, right? Or Dr. 1's patients are twice as sick from a patient acuity perspective as Dr. 2's. Do you think that's true? Right? No, it's probably not. They're both in the exact same city. They're both in the exact same practice. They're both seeing the exact same type of patients. And if you do some deeper analysis, you'll see that that's true. So what we're going to do is we're going to look at some regression analysis to compare what happens when Dr. 1 sees a patient whose primary diagnosis is hypertension, and Dr. 2 sees a patient whose primary diagnosis is hypertension. They're both seeing this patient for the same problem. Dr. 1 uses other HCC codes as comorbidities as subsequent diagnosis codes nearly 1 out of every 3 patients. Dr. 2 does that nearly 1 out of 20 patients. So are Dr. 1's patients that much sicker? In reality, the answer is no. When you're looking at the data, the answer is yes. Right? The difference is in how they code. Right? So we can use this data to help make our practice better. We can use this data to help train our clinical staff, train our doctors, train our nurses, train our PAs, train our MAs, and we can use this data to help our revenue cycle team identify these types of opportunities. Right? This allows me to provide very helpful, specific training and education to my doctors. So let's dig a little bit deeper. And for this practice, when they see a patient with a primary diagnosis of hypertension, the code is I-10, it's one of the ones that I can remember off the top of my head. When they see a patient with a primary diagnosis of hypertension, these are the top 10 HCC codes that most frequently go along with it, right? So these are the other conditions that a patient with a primary diagnosis of hypertension is most likely to have, right? And going back to our survey data, we think about 60% of you are probably doing a great job of documenting these other problems today, but less than 20% are doing a good job of coding them today, right? So that's where we need some help. That's where we need to make improvement to our workflow and to our process. So let me show you how clients have operationalized this in their practice, okay? We'll start on the clinical side, and then we'll go to the back office and look at it there. Right, on the clinical side, what they did, if you'll notice, they've got that hypertension diagnosis here towards the third column, towards the bottom on this particular encounter form. And when they click on it, they select that I-10 diagnosis code, right? Pretty easy, pretty straightforward, pretty simple. What about those other comorbidities? Well, if the provider, if the doctor, if the nurse, if the clinical team wasn't going elsewhere and selecting those codes, it really wasn't being communicated at all from a coding perspective. Maybe it was from documentation, right, but it wasn't being coded. So how do they make that better? Well, watch this. What they did, no change to the look and feel of this, but when they click on that code, it gives them a pop-up, what we call a custom scenario, that shows not just the primary diagnosis of hypertension, I-10, but it also shows them those most frequently used HCC codes from that regression analysis, right? These are the most likely other problems this patient should have. We know that one of the better performers does one of these codes nearly 33% of the time, and we know that the worst performers are doing that 1 out of every 20 times. Our goal is to accurately reflect patient acuity so that I can select one or more of those codes as appropriate for this particular patient encounter, right? And remember, we talked about last time, as long as it's documented, as long as the condition existed at the time of service, it is appropriate to code it per the Medicare guidelines. And I've got the link to those guidelines in the slides from last week. All right? So that's one way to handle that. I'll show you another way that I thought was particularly creative that one of our clients did. They put a little, the only thing that's different here is they put a little HCC box out to the right. And what that allows me to do is it reminds me, oh yeah, you may want to code some of those other HCC comorbidities. You can still code just the primary diagnosis if that's all that they have. You don't have to do anything else. But if you want to see those comorbidity options and you click on the HCC code, you will get those same customized list of 10 HCCs. So all of that is customizable. All of that is done within our application. That's how our clients handle it. Other people will build that in their templates in their EHR. There are a lot of different ways to do that. It really depends on what your workflow looks like today. But I'll show you how that works in our application, how we try to make that as easy as possible for our clients. You can use this analysis to drive your workflow however you handle that in your particular practice, in your particular organization. So if I want to help my clinical team with that, right, that's the easy way for me to do that. What about on the back end? What about the times when something slips through the cracks, right? My doctors are in a hurry. They don't capture any of those HCC codes. Well, going back to that workflow tool that's on the back end, right? Let's say that you put that in your template in your EHR. You're generating that charge data automatically, right? But sometimes doctors make mistakes, right? This group, what they did was they built in a rule that says when I see a patient with a primary diagnosis of hypertension, right, a primary diagnosis of I-10, I want you to stop me if you don't see any of those other HCC comorbidities, right, because it looks like we may have missed something here. I know that I don't expect to see that on every single encounter, but some people who do a really good job with this, they have HCC comorbidities on over 50% of their encounters, right? Because they're doing a good job documenting them and they're doing a good job coding them as well. And you want to make sure that you're doing both. You want to make sure that you're doing both. So what they did was they built in this rule. Now, they showed not only kind of in the rule what was wrong, but they also showed here are the most frequent codes that we expect you might use along with this. Here's what the ICD-10 code is. Here's what the description is. Now, if you want to also have the pop-up, you can have that. You can right-click on that ICD-10 code, and you can get that same custom scenario that we looked at before. Again, that allows me to select the additional HCC codes that we have for that particular patient encounter. Obviously, you want to make sure that that is documented. You can't code it if it's not documented, but it's a tool that's helpful for the back office staff or the revenue cycle team to make sure that that is coded correctly and that we're not missing or underrepresenting any of those HCC codes. We're not underrepresenting our patient acuity because that has a negative impact on your cost scores. It has a negative impact on your quality scores as well. All right. So when I select those, obviously, you see that those get added back in to my list, right? And I'm accurately reflecting patient acuity here. All right. Now, I know I went through that quickly. I know that I went through a lot of information here. But what we want to do is we want to make sure that we give that education. to our clinical team, and to our revenue cycle team. That we show them why risk-adjusted coding is important. That we show them why that matters to them, right? Why that's important to them. We can do some analysis to look at what codes you're using today, how your doctors are performing today, do some of that regression analysis that looks at your primary diagnosis codes and what HCC codes you should be using alongside of them. I think that's very, very valuable. Hopefully the education that we've provided is helpful for you. If you're interested in some of that type of analysis, we can do that as well. So if you're interested in looking at that, let me know. You can put that in the questions panel, and we'll get some information to you on what that looks like and some sample analysis, that sort of thing. So I think that's a great place to start. If you haven't done that already, if you're in the 80% who aren't tracking HCC codes, if you're in the 80% who are not coding that today, I would certainly recommend that as a good next step, is doing that level of analysis, because that will show you where you need to make improvements to your process and how you want to make those improvements in a balanced way to engage both the clinical staff and the revenue cycle staff, right? We think White Plume has some great tools to help you do that. If you're interested in talking to us about that, wonderful, let us know. If not, no problem. You can use the analysis to help shape your process, whether that's completely manual or completely done within your electronic health record or somewhere else. But once you get done with that, you want to go back and do some analysis again to review your progress and determine how well you've done so far and where you still need to make some improvements. This is not going to be a one and done cycle. You're probably going to have to do this multiple times to make sure that you are consistently and accurately reflecting the acuity of your patient populations. All right? So what are the takeaways from today? Let me go through this quickly, and I'll try to answer as many of your questions as I can. Diagnosis coding is going to be much, much more important in the future than it ever has been before, right? We've got those two big changes looming. October 1st, more specific diagnosis codes are going to be required. Those unspecified codes aren't going to cut it anymore. The CMS grace period expires, and we expect that the commercial payers will follow suit. If you need more information or have questions on that, I couldn't get into a lot of the details on that today. Just let us know. We can help you with that as well. But the bigger change is going to be capturing those comorbidities, specifically making sure that your risk adjustment is done accurately, right? Risk adjustment is critical in the value-based reimbursement world, and that's where we're headed. Risk-adjusted patient acuity is going to impact your quality scores and your resource scores under MIPS. The MIPS measurement, the performance year under MIPS begins right now. The proposed rule is that will begin on January 1st, 2017. So that'll be the performance year. The government will have to crunch the data in 2018, and then you will receive your positive or negative adjustment in 2019, right? So there's a 2-year lag from performance to payment, or a 2-year lag from performance to penalty. Hopefully, most of you will be on the payment side, not the penalty side, right? So that'll be important under MIPS, right? We want to make sure that your quality scores, that your cost scores that are measured against your peers accurately reflects the high value and excellence that your doctors provide. And the only way to do that is making sure that your risk adjustment is done correctly, right? There's not a hard and fast number that you should be shooting for. The goal is to accurately reflect patient acuity, right? Most people are not doing that today. Most people's patient acuity looks much lower in the data than it is in reality. And that's what we want to help you fix. That's what we want to make sure that you're focused on. We talked about a 4-step process for that. Providing some education, clinical staff, revenue cycle staff, assessing the data, doing some analysis, doing some reporting to show where you are today, where some places are where you might want to make some improvements, so that you can begin to operationalize that. You can put that into practice in a balanced way that engages both the clinical team and the back office revenue cycle team. Once you do that, you want to go back, review your progress so that you can continue to make that improvement, right? We've got some great tools that will help you do that, to make that easy for your doctors, to give your billing and coding teams an opportunity to review and correct mistakes that your clinical team might make. If you want information on that, again, let me know in the questions section. I'll get somebody in touch with you. If you're interested in doing some of that data analysis, we've got some data analysis that we can do that is no charge. We also have some paid analysis if you want a bit deeper dive into that. We can talk to you about both of those things. Just let us know in the questions panel, and we'll make sure that we follow up with you on that. Thank you again for your time this afternoon. I hope that this has been helpful for you. I'm going to open it up to the questions panel and try to answer as many of those as I can in the remaining few minutes. Don't forget, one last request from me. Please take 30 seconds to fill out that survey when you close the webinar. I look at every single one of those and would greatly appreciate your feedback. Okay, several people asking for a copy of the slide deck and links to the recorded version. Yep, we will send those out to anybody who asks for them. If you haven't asked for those and you'd like them, just put it in the questions panel and we'll make sure that we get those to you. Question here on when will or when did the scoring period begin? That's a great question. The scoring period for MIPS is currently scheduled for January 1st, 2017. That's the proposed rule. That is not a final rule yet. There are, of course, lobbyists and trade groups who are trying to get that extended or pushed out, which is probably no surprise to any of you. However, I would tell you that the scoring period has also already begun, right? HCC coding has been around since 2004. Medicare has been using that under Medicare Advantage plans. They have used that with ACOs. They have used it for transfer payments between insurance carriers under the Affordable Care Act. So your payers are already deep into HCC and risk-adjusted coding. They are already using this data. They are using it to look at patient acuity. So the game has not started for MIPS yet, but the game for HCC coding has already begun. So sorry, that's kind of a two-part answer to that question. Yes, people are looking for where can you find the HCC weights. The HCC weights are available on the CMS website, but it's pretty cryptic. It's not the easiest thing to find and dig through there. There are some tools that they make available to try to get at that. We also provide that in the analysis packages that I was talking about. So that may be another way to look at that. We've got some analysis that we can do that we can provide for you that's complimentary. We've got other that's paid, just depending on how deep you want to get into the analysis. Let's see. Yeah, if you like the examples that were on the super bill, that'll be in the slides, so you'll be able to get a copy there. And the something for all individual practices, physicians, regardless of specialty. Yeah, that's a great question. So MIPS is something that applies to all physicians that are participating in Medicare. That is another government program, another incentive program. Everybody will be participating. It's not one of those that you have to sign up for like you did in meaningful use. So everyone will be participating in MIPS. There are two tracks. APM is the other track, but most people won't be doing that. If you're going to be going down the APM route, you already know that. So if you don't know which track you're going down, the good news is you'll be in MIPS. So everyone will be participating in that. Everybody will be getting that score from 0 to 100. And your adjustment under MIPS will be made based upon your score and how you do compared to your peers. The comparison, some of that comparison under the cost measures will be measured against your peers in your specialty, but the total MIPS score will be measured against all other providers. So again, apologize, it's a long-winded answer, but like most government programs, they don't make that very simple or straightforward. So I hope that helps you. Okay, I think I'm up to the top of the hour. I think I want to be respectful of everybody's time. But thank you again for your time this afternoon. I hope that it was helpful for you. And please remember, take 30 seconds just to answer that 4-question survey for me, and I would greatly appreciate it. I'll leave the questions panel open for a few more minutes for any last-minute questions, and we'll try to follow up on those for you offline. Thanks so much. Have a great afternoon. Bye-bye.